Hello, my name is Ravi Vij from MyCancerHaven, and today in Conversation with Cancer Expert series, we have Dr. Gregory Roloff, a rising star in the area of heme malignancies, leukemia, and cellular therapy. Welcome, Greg.
Thank you, Ravi. I appreciate you having me.
So we're going to talk about CAR T cell therapy for acute lymphoblastic leukemia. So, Greg, can you first start off by telling us what are the FDA-approved drugs in this area?
Certainly. So your slide nicely delineates the three FDA-approved products here. They have big names, and so a lot of times, on the ground, we'll use abbreviations. And so, for example, for Tisagen Leclucil, we often call it Tisacel for short. For Brexacaptogene autoleucel, we'll call it Brexucel for short. And finally, for Obacaptogene autoleucel, we'll cell it Obicel for short. So these are the three products. The thing that I would point out that is important to know about the label and the indication is that Tisacel or Tisagen Leclucil is largely a product that is used in the pediatric and young adult space, and it's only approved right now for patients up to the mid-20s, and so largely used in AYA programs. And then Brexucel and Obicel are the main players that you'll see on an adult cell therapy ward or in an adult cell therapy clinic. The few distinctions that are delineated here, I think, are important ones to know. They're a bit more granular, but this is just to say that there are some detailed discrepancies of the design of how these CAR T cells are meant to activate and meant to persist. And that tracks with some of the co-stimulatory molecules and binding domains. And a lot of folks in my world like to waffle about these slight differences and whether or not they have implications for the way that the CAR T cells behave and the way the patients do with them.
So let's review the trials that led to these drugs approval. So the first one I think that got approved was Tisacel. So can you tell us about this trial?
Yes. So Ileana was the trial that allowed ultimately for Tisacell's approval. And, Ileana was significant because it was the first truly global CAR T cell trial in the peds, adolescent young adult space. I think there was 25 centers worldwide. So this was not a single center tour de force. And I think that matters when you're thinking about deploying CAR T cell therapy in a more widespread fashion, outside of Houston or Philadelphia or St. Louis. And the dosing schema is shown here. We use fairly standard fludarabine and cyclophosphamide for lymphodepletion to manipulate the host's immune cells before T-cell infusion so that the CAR T is maximally positioned to be effective. The primary endpoint of this study was overall response rate, which encapsulated both CR and CR with incomplete hematopoietic recovery within 3 months. And then beyond that, in the secondary endpoints, they studied MRD negativity built into those composite CRs, survival, and then some elements about duration of remission in leukemia and event-free survival.
And so how efficacious did it turn out to be?
Yeah, so this is a good drug. So as you're seeing here in these Kaplan-Meier curves, depicting duration of remission and then event-free and overall survival. And I should say we have 3 and 5 year data now. This being the first real CAR T cell product, it also grants us the ability to have long-term follow-up. And so, at 3 years, for example, event-free survival was 44% and overall survival 63%, likely reflecting the efficacy of salvage therapies if patients were to go on to relapse. And, at 5 years, even the
Right.
relapse-free survival was still right around 44% among those responders without any new safety signals. So that it kind of it argues for this true curative fraction in what is a heavily pretreated population. And the other question this begs is whether or not everyone needs a transplant on the back end. A decent fraction of long-term survivors in Ileana did not go on to receive a consolidative allogeneic transplant, which I think kind of challenged the reflex notion that CAR T was just a bridge, and it opened the door to the idea that at least in some kids or AYAs, that CAR T alone could be a curative therapy.
And how was this tolerated?
So, reasonably well. I mean, I think we've learned a lot about how to best manage CAR T cell toxicity since then. And the toxicities that you'll see here, I mean, we break it down by any grade and then grade 3 or 4, as most patients will experience some degree of cytokine release syndrome, which essentially looks like a bad influenza or sepsis, right? It's fevers, chills, sometimes low blood pressure, need for oxygen. It looks like a sick patient in the hospital who's getting septic. Um, and then the other major toxicity that we pay attention for is neurotoxicity, or sometimes called ICANS, which stands for immune effector cell associated neurotoxicity syndrome. And what you'll see is that most patients will have some low-grade toxicity, but as you go across and look at the proportion of those who experience grade 3 or grade 4, you'll see falling numbers. And there wasn't tremendous discrepancy in terms of patients who did well versus who did not do well from a leukemia standpoint, although there are some slight differences here. And then just at the bottom, a good chunk of patients will experience febrile neutropenia. Kind of goes without saying, if you're going to have cytokine release syndrome, the idea that you're going to be both febrile and neutropenic during that window is reasonably high. And the other thing that I've been able to appreciate in some of the longer term follow-up of Ileana is that more of the late toxicities are probably immunologic in nature. So long-term follow-up hasn't shown new neurotoxicity or organ signals, but infection risk and hypogammaglobulinemia from prolonged B-cell aplasia are very real. And so, the late toxicity conversation is less CRS and ICANS or neurotox focused and more kind of chronic IVIG vaccine responses and infection stewardship focused, because due to the success of these therapies, we do have a fraction of patients who are living 10 years, but they're going to be doing so in an immunocompromised state.
And then let's talk about the second one to market. That was the Cartus or Bruxisel.
Yes.
So,
So this is shifting purely to the adult space, and Zuma 3, which was a phase 1/2 open label international study that enrolled adult patients who had relapsed or refractory B-cell acute lymphoblastic leukemia, and by definition had to have greater than 5% blasts, although, as is nicely pointed out here, patients who had previously been exposed to a different type of CD19-directed therapy, blinatumomab, were allowed to enroll. And slightly higher doses of cyclophosphamide and fludarabine were used here compared to Ileana, but then again, it is an adult population. And all patients are getting 1 × 10⁶ cells per kilogram on the day of infusion. Because this is a relatively rare disease in adults, and CAR T-cell therapy is an uncommon indication, at least right now, for this rare disease. This was a relatively small study of about 55 patients who were ultimately infused. And the endpoints shown at the bottom of your slide here were first to characterize dose-limiting toxicities in the phase 1 portion, and then to think more about response rate in the phase 2, with key secondary endpoints pertaining to both the duration of that response and MRD status. And then there was some translational work done as well, studying the persistence of CAR T cell levels in the blood and serum.
so how do patients fare on this drug?
So one thing that's important to point out is that, generally speaking, as patients become more and more heavily pretreated and still have disease that is able to be targeted with a CAR T cell therapy, that we're probably enriching our patient population for those who have adverse risk or high risk disease biology. And so, while the overall CR/CRi rates are in that 70-ish% range for all patients, there are some distinctions that can be broken down, especially for those, for example, who were previously exposed to blinatumomab and have lower response rates than those who are not, or inotuzumab and those who are not. So these were not strongly statistically significant differences, but it is something that's important to point out. And and begs the question is where exactly we should be sequencing CAR T cell therapy in our armamentarium. Sort of like with myeloma, we have lots and lots of drugs. Well, where exactly should they come in, and what's the best way to get somebody there? There's many roads to Rome, as they say. And then the other thing that I'll mention, and this is depicted in your last column there, is prior transplant. And so, the one of the things that we're starting to wonder is, specifically with regard to where CAR T cell therapy comes into play, is there a benefit to ultimate ALL outcomes if we're making a CAR T cell product off of donor T cells, right? A refreshed T cell repertoire that hasn't seen 4 or 5 previous lines of therapy, or on the flip side, should we try to consolidate our remission by bringing patients to a consolidative allotransplant after CAR T? That's a topic that we're actually studying right now. We don't actually know what the best transplant sandwich is surrounding CAR T, but it's an area of active investigation.
So in this trial, how do people do long term?
So this is a highly effective CAR T cell product. And remember, I mean, this is a highly pre-treated and high-risk disease population. And so shown here, which was presented by Dr. Oluwole at EHA, and we now have a publication with longer-term follow-up that was recently published by Bijal Shah as the first author in the Journal of Leukemia. The median overall survival for all comers was over 2 years, so 25.6 months. And this will kind of nicely stratify amongst various degrees of response. So patients who had the cleanest complete remissions versus those who had kind of this ineffective count recovery, there's a distinction there. And non-responders at the very bottom obviously do the most poorly, again, likely enriching for those with the higher risk populations. You astutely point out that though there were some less pronounced differences for people with prior Blina or INO exposure. I think that might likely just be due to disease biology. For example, we know that P53 mutations make patients more prone to CD19 loss, and that's one of the well-known mechanisms of escape for CD19-directed therapies like Blina or Brexucel. And the last thing I'll notice, and this is something we're still trying to wrap our head around, is that Brexucel, the benefit that we were able to observe was very consistent across any type of stratifier or subgroup that we can do on a multivariable analysis. So regardless of age, regardless of prior therapies and subsequent allotransplant, it seemed to hold up.
How is this tolerated?
So this is an evolving story. We know obviously for patients who get CAR T cell therapy, the expectation is that most will experience some degree of low-grade toxicity. So the majority of patients, as you'll see, are, we're talking 80–90%, are going to have some low-grade CRS, and relatively few actually in the high-grade CRS with Brexucel. But one of the problems that many patients pay attention to with Brexucel is what some might label as concerning high-grade neurotoxicity. So this is grade 3 or 4 neurotox, where somewhere between 25–30% of patients are experiencing very high-grade ICANS that clinically can look like, seizures, admissions to the ICU, comatose neurologic events. And it's not exactly clear to me, if ICANS itself kills patients, or if it's part of a constellation of a sick individual in the hospital who has low counts, who's at risk for infections, and then we're superimposing neurotoxicity onto that. But that's the reason that, at least for this CAR T cell product, compared to some others that we'll talk about in the later half of this talk, like Obe-cel, this product is, to my knowledge, almost exclusively given in the inpatient setting, where in other spaces in CAR T, I know this is true in myeloma and some lymphoma products as well, we're trying to identify the patients whose safety profile probably best fits with outpatient administration. But at least in my opinion, for relapse refractory ALL in adults with Brexucel, this is something that's best given inpatient. And the higher grade neurotox is part of the reason that I say that. The last couple of points here I think are just good to hammer home. We see most of our toxicity early on, at least from the standpoint of CRS and ICANS. we're not uncovering late neurotoxicity that presents, months or years later. These are generally things that we see pretty early. And this is not one of the products where we're seeing, T cell malignancies that are arising from the CAR construct, as has been the case in some of the other lymphoid malignancies.
And there's already some real world data with this product.
Yes, myself and Lori Muffley at Stanford have been leading this real world effort because ALL community in adults is relatively small, and so it's conducive with getting everybody together and really asking what questions, if we can pool all of our data, all of our resources in the right way, just how boutique of questions could we ask? And so we thought we would start with kind of a top line results of just describing in a much larger cohort of patients that was infused on Zuma-3 what are the top line results? What are the patient characteristics who are actually getting Brexucell in the real world? As we know that patients who participate in studies are not perfectly reflective of individuals who are getting this therapy on the ground. And, we did, in the same way that we saw very high rates of response with Brexucell in the real world, we also saw that concerning signal for higher grade ICANS at 31% in this paper.
Well, congratulations on that well put together study.
Thank you.
Let's move on to the third product that you briefly referred to a few minutes ago,
Mhm.
Obicell.
Yeah, Obicell is the newest player in the CAR T space for adult ALL. It was approved right at the very end, I think in December of 2024. And most sites, because launching a CAR T cell product takes a little bit of time, some contracting, some back and forth with these companies. I would say most places in the United States are still in that first 6 to 8 months of being able to give this product on label. And so we're still learning, how to best deliver it. But Felix was the name of the study that ultimately led to the FDA approval of Obicell. And it was an international open label single arm 1-2 study. One thing to mention about Felix is that it did include patients who had extramedullary disease to be allowed to enroll, which has been a long plaguing exclusionary criteria in a lot of ALL studies. And the other thing that it's important to mention here is that patients with Ph positive disease who have seen prior TKI exposure but experience disease recurrence after that were also allowed to enroll. The one other thing that's important to point out is that most of these patients look pretty good. So they all had an ECOG performance. The great majority had an ECOG performance status of 0 or 1. So these are relatively fit people. And while not shown on the slide here, most of them had probably 2 or 3 prior lines of therapy, but not 5 or 6, as sometimes I've met in the real world. The thing that's important to know about Obicell is there's some additional mechanics of the cell dose administration compared to the other products, which are just given as a single dose infusion. So Obicell's infusion is a split dose, and it is based on tumor burden. And if you were to wonder, well, why that is, one of the hypotheses is that some of the toxicities that we see with CAR T cell therapy might be to the fact that this is a very potent medicine, and if there's a lot of disease around, it might overwhelm the system from an inflammatory immunologic perspective when those CAR T cells go in, quote unquote, guns blazing. And so the hypothesis was that by splitting up the CAR T cell dose, we might be able to maximize our anti-leukemic efficacy while sort of spreading out or mitigating some of the concerns around toxicity in this patient population. And so for patients who have fewer than 20% blasts at a pre-lymphodepletion bone marrow biopsy, they will get a larger dose upfront of 100 million CAR T cells and on day 1, and then 9 days later on day 10, assuming that they're not experiencing high-grade toxicities at that point, they'll get a second larger dose of 310 million CAR T cells. And then that we kind of flip the script for patients who have higher disease burden at presentation, or at lymphodepletion, I should say, I'm sorry. And that is they get a much smaller dose of just 10 million CAR T cells at the time of initial infusion on day 1. And then assuming that they're doing well, they get a much larger dose later on. And like I said, this was all for the goal of toxicity mitigation. as I mentioned, this was a phase 1/2 study. So the phase 1 component was all focused on safety, and then we shifted to overall response rate for the phase 2.
And how did patients do on this study?
Sure. So you're seeing the different cohorts, and basically A and B and C are different ways to describe these patients. And so because it was much bigger and it was the what ultimately led to the registrational component, let me hone in a little bit on the cohort 2. So cohort 2A was patients who kind of looked like that with Brexacel. These are individuals who have greater than 5% blasts in the blood or marrow and have kind of overt progressive or relapse disease. Cohort 2B were individuals who had just measurable residual disease positivity, but were coming to obe-cel in a state of morphologic remission. And cohort 2C, only 7 patients, but at least represented in a trial in this rare disease space, were individuals with isolated extramedullary disease. And so, the statistics and the kind of mechanics of the trial design were such that the null hypothesis would there would be a less than 40% overall response rate and a less than 20% CR were rejected. So obviously we went on to eclipse those, and the CR in probably the most pertinent disease cohort, which was 2A, those with more overt disease, was 77%, and we saw 100% response rates in those with just MRD positivity, likely underscoring the fact that CAR T cells are probably, they could be thought of like cellular blinatumomab. They do better with smaller amounts of disease, and they're really good at sweeping up MRD and low amounts of disease burden. But if you're giving CAR T cells to patients with 70 or 80 or 90% blasts in the marrow, you would expect lower response rates for somebody than with just MRD alone.
And how did these people do long term?
Right. So we're seeing the event-free survival Kaplan-Meier curve here. And the important thing to point out is that this was censored if patients went on to receive a consolidative transplant. And we're going to ultimately allow for longer term follow-up and longer readout of this, but we're seeing event-free survival, at least in this curve, of 11.9 months, acknowledging that actually the majority of patients did not go on to receive transplant in this population. And in post hoc analyses, the event-free survival for the younger group of patients was about 14.5 months versus 11 months for those who are a little bit older.
And what about survival?
Right. So survival looks good too. And like I mentioned before, we're going to be hearing longer term follow-up for patients, pretty soon with that at the three-year mark, with median overall survival probably eclipsing what is shown here. But at least what we have right now is a median of overall survival of 17 months. And again, some discrepancy actually from what we saw before. So for the younger patients, less than 55 years, we're seeing 16 months, but 23.8 for those older than 55 years. And this is sort of a puzzling observation that we're struggling to wrap our head around right now in the field, and it's something that is going to be the topic of future study.
And how was this tolerated?
Yeah, so I think this is probably one of the finer points that I would like to make today is that the safety profile of obe-cel appears to be superb. And we're studying this in the real world right now too, just in the same way that we did for Brexacel, to make sure that the patients who are receiving this on the ground look like those who received it on trial. And I think it's important to have a little bit of healthy skepticism there, because the patients who received this drug on trial had very favorable toxicity profiles. So, we are talking single-digit percentages of high-grade CRS and ICANS. And we're not seeing late onset CRS and ICANS either. So this allows us to believe that if patients are getting those 2 doses, they could probably go home by day 14. And this even begs the question of whether or not we should start doing this outpatient. That's very center dependent. It's not something that FDA dictates to us. But the toxicities, like I said before, they typically tend to stratify with patients who have higher amounts of bone marrow involvement of their disease beforehand. So the relatively few cases of high-grade CRS and ICANS that were observed were for individuals who had higher bulk of disease in their marrow going in.
And then let's talk about a few products that are in the pipeline and may be commercialized in the future. So I understand we're even looking at dual targeting CAR T cells.
Yeah, so this is a clever design, and I think it makes a lot of sense because if you think before the CAR T era, we had blinatumomab and we had inotuzumab, and one target CD19 and one target CD22. And so, sort of like a barrel of monkeys, we would just use one after the other, and some doctors would like Ino first, and some doctors would use Blina first. And if we assess someone's disease after Blina or after Ino, the question that we would be asking ourselves is, well, has expression of the other target been maintained so that we can use the other drug? And it begs the question, well, what if we went in with a dual targeting, or sometimes known as a bicistronic CAR T cell, where we can theoretically generate deeper remissions up front by targeting both of these important antigens? And so this is the topic of a few different trials at various places like WashU, like Medical College of Wisconsin. I think we're at University of Chicago, we're launching a trial of a dual CAR T cell soon for relapsed refractory lymphoid malignancies. And I think actually some of these might be highlighted at the ASH meeting this year. I must admit, I've yet to make the schedule of talks I'm going to go to,
Sure.
posters I'm going to visit. But looking out for these reports of these early phase 1 trials for CD19 and CD22 targeted CARs is definitely the way of the future. And the other thing that I'll mention is that in addition to going after antigens in a more strategic way, the design of some of these CARs is really advancing as well. And so CARs have more sophisticated on-off switching and gating to allow us to sort of control the way that they are behaving in the body. And so if somebody were to be experiencing sort of idiopathic toxicities that are out of proportion from what might expect, there might be ways to enable what are sometimes called suicide switches or off switches to shut the CARs off. And that will be important because this is a new paradigm of this dual targeting. We don't know exactly how these drugs are going to behave in the body when previously we were just going after one antigen and then the next.
And then another paradigm shift that may occur at some point is the use of allo CAR T cells, off-the-shelf CAR T
Right.
cells.
Yeah, and you can imagine in some way this is sort of already being done, but in kind of a backdoor manner, right? So if somebody had a prior allotransplant and relapses, and you make a CAR T cell product, but in the meantime you're trying to get them into remission, and let's say you infuse a patient who has a little bit of MRD left, but who has recovered their chimerism at the time of apheresis. By and large, you're giving allogeneic or a large, strong representation of allogeneic CARs to that patient. Uh,
Sure.
but going straight from a donor actually is a provocative idea as well, because a lot of folks who work in the T cell biology space talk a lot about T cell fitness. And I think that term, it's a little bit of a loaded term. It means different things to different people. But from a simple country doctor clinician like me can easily envision that somebody's T cells from which we would be making an apheresis product are probably going to be able to, more effectively be supercharged if they've not seen 6 or 7 lines of therapy, and not seen cytotoxic chemotherapy or other agents like venetoclax that we think might rewire some of these T cells from within. And so if we were to go to an outside donor and make an allogeneic CAR T cell product, we might have some advantages to be captured in terms of the power of what we're infusing. And so UCAR22 is a study that's being led by Nitin Jain at MD Anderson and is enrolling at sites nationally now. And this is an allogeneic anti-CD22 engineered CAR T cell therapy. Because a lot of these patients have had prior transplant, we need to think about graft versus host disease induction risk as well. And so there are some elements that I believe are proprietary, but are engineered to try to minimize GVHD risk with this construct as well. They've reported some early results, which I think so far are mixed. One of the things that we're seeing, I've had a few patients who have gotten this, and one of the things that we are seeing is that even though we're able to successfully salvage some patients with these CD22 CARs, the CARs do not persist for a long time, and the responses can be relatively short-lived. And so, in the few patients that we've seen respond so far, the idea would be to try to get them to a consolidative allotransplant. But this might be, an area that is opportune for future development because it's kind of a first proof of concept or first of its kind hypothesis. And I'm excited to see this study read out in the future.
And they're also going after CD19 as an allo CAR T target.
Yeah. So it's a little bit harder of a name to get off the tongue, but RDO 603. So this is a completely different design. There's this molecule that I'm still trying to understand called the answer molecule, which sounds kind of very prophetic. Uh, and it's designed to enhance and persist not just T cell but NK cell activity against relapse refractory B cell ALL. And this is a CD19 targeted CAR. It's still in kind of the early phases of this study, so we're just at the dose limiting toxicity as our endpoint right now, and we'll see. I mean, we are starting to see responses in 5 patients of the 6 infused, most of those being MRD negative responses, and whether or not count recovery and cytopenias might be a limiting factor with this particular construct is one of the questions that I have in my mind, and whether or not, like with UCAR22, we would be more inclined to try to bring people to allogeneic transplant is another looming question.
Well, bring it all together. So, where do you use CAR T today?
So I think my practice is actually changing right before my eyes, and part of that is because I work at a medium to large sized academic center, and part of my practice is referrals from docs around the Midwest saying, "Hey, I have this patient with ALL who has seen every therapy imaginable except CAR T. Can you salvage them?" And the answer is usually I'll try my best, but every once in a while we have patients with such explosive disease that the logistics and the feasibility of actually getting them apheresed and delivered seems quite difficult because of just how sick they are by the time they're referred to the CAR T cell center. And we've come to appreciate that CAR T cells do better at cleaning up lower amounts of disease. And so it begs the question, before we allow for those multiple relapses to select for a disease biology that is leading to these more explosive relapses that are difficult to control and difficult to treat, extramedullary relapses, which are incredibly difficult to treat, should we perhaps be using CAR T cell therapy in earlier lines? The label for obe-cel and for brexu-cel, for example, is just for relapsed and refractory disease. And so theoretically speaking, somebody could be apheresed and get this in first relapse. And at least, it's cross-trial comparison, so we're told to never do it, but we all do secretly. If you were to consider the duration of response or the durability of remission for inotuzumab or blinatumomab versus CAR T cell therapy, CAR T cell therapy probably wins. And I think the question will be, is there something about prior exposure to blinatumomab or inotuzumab, which do not take, several weeks to make the product? They're a little bit more financially feasible, although they're still expensive medicines. And at least with INO, it's very off the shelf and inconvenient to administer in an outpatient setting. So, will individuals who have prior exposures to those therapies do better or worse with, subsequent CAR T? That's a question that we're actively trying to answer with this whole sequencing debacle. So for me right now, especially for older patients who are probably not transplant interested or transplant eligible, I'm looking for CAR T in earlier lines of relapse. And for younger patients, I'm still a little bit hesitant to give CAR T cells as a destination therapy. I think if I'm a doc who's caring for a 35-year-old patient with relapsed ALL, and I'm lucky enough to get them into a remission with CAR T cell therapy, if they've not yet had an allogeneic transplant, I'm probably going to allograft them. The difficult question becomes if you have a younger patient who, despite their young age, is still seeing lots of lines of therapy and already one transplant, what is the cumulative lifetime toxicity and what is the patient journey of experience of trying to get them another one? And how do I weigh that against the possibility of long-term durability, persistence, and CAR T cell mediated remission? So those are the things that keep me up at night. But to end on sort of an optimistic or happier note, we have great options now for relapsed refractory ALL. This is very, very different from the outcomes even in my lifetime, in the 90s and early 2000s before we had these immunotherapeutics where the response rates with salvage chemotherapy were in the low single digit percentiles, and very few patients were able to be successfully salvaged. And so in today's day and age, we've seen a bit of a watershed or a tide shift. And I think the question will be just how do we best use and sequence the tools that we have in our toolbox?
So you said it right. The lot of unanswered questions, but exciting times. And I hope I can have you back in a future date to answer
Yeah,
some of these unanswered questions for us. Thank you very much for this excellent presentation, and I hope I can rely on you to come back and talk to us some more in the times to come.
of course, Ravi. It was fun seeing you. Thanks again.
Thank you.